circle.
Everyone please be quiet. Thank you. People in the back. Please be quiet and settle down. Thank you. Thank you. People in the door can come in if they can.
Maybe they should sit towards the front. If you guys want some floor space, please come towards the front. You can sit maybe on some floor space here. Lean against the windows, perhaps. Come on in.
Okay. Just to inform everybody, to confirm your attendance. Your attendance will be taken after the presentation, and there will be laptops in both sides of the doors, so you can put your attendance there. So our speaker, Dr. Sonali Srivastava, is a Vanier alumna and is a family physician who graduated from McGill Medicine School and has a master's degree from Oxford University in Medical Anthropology. She will speak to us today about women in medicine. We are honored to have her here today. Welcome back to Vanier, Dr. Srivastava. Everyone, please join me in welcoming Dr. Sonali Srivastava.
Thank you. That was a very warm welcome, Tracy. Thank you for volunteering or being forced to introduce me, I'm not sure, but it was great. And wow, what a great turnout. Thanks already for showing me how much you care. This is awesome. Whether you're here because you wanted to be here or your teacher promised you some extra marks, doesn't matter for me. I'm just glad you're here, and I'm so glad that you're going to listen to me, hopefully for the next 30 or 40 minutes. So I'm going to start off. I would like to say it's especially meaningful for me to stand here and speak about two things I'm extremely passionate about. One of them is medicine, and the other one is feminism, as you might have guessed. So who am I? Just so we know each other a little better, I'd like to describe my career path a little bit further. I graduated from Vanier College in health science and went on to do biochemistry co-op at Concordia University. I thought at the time, if medicine doesn't work out, I'd have a solid path to scientific research that I could pursue and be happy in. Perhaps a lot of you are thinking the same. Well, as life would have it, with its unexpected twists and turns, by the end of my undergraduate degree, I didn't know much, but I knew one thing for sure, which was I did not want to do medicine, nor did I ever think I'd ever apply to medicine. I thought, why would I want my life to be about death and dying? I want my life to be about the living. I want to have fun, and I want to travel. I was inspired by the people in my life to try to get into international health work. Actually, mostly my sister. I wanted to still work with the needy in order to help them, but in a much, much different way. Of course, I had zero skills, nothing to offer, no experience. So I did what the next person would do. I tried to get another degree. And I thought, well, I wanted to do a master's. I didn't think it was going to be useful to do another undergraduate. So I thought medical anthropology might take me seriously as an applicant. After all, the biochemistry part was medically related. But it was really the anthropology part that I was after. Anthropology, the study of human origin, society, and culture relating to medicine. Yep, it sounded perfect. And it was. I could use it to understand people's environments and culture in order to best serve them and make a positive, sustainable change. After that, I went on to do some volunteering work and some internship work in India and Bangladesh, mainly again with disadvantaged women and infection prevention. It was great to grow as a fledgling professional, but in my mind, which was very annoying to me, something kept wandering back to medicine, that original idea. I'd flick the thought away, I wouldn't really think about it, I didn't let myself, but it kept creeping in. I don't know if some of you have the medicine bug. But it wasn't until I was actually working right here in Vanier College, in the Learning Center actually, organizing international projects for students just like you, that I had the courage and I decided I need to apply. I need to see what happens. And I'm so, so glad I did. And here we are. So that was me. I want to know who you are a little bit. So I just want to know, how many people here are in health science? Oh wow, so that's like a big majority, okay. And how many people here are in social? Oh, good. Are there any other programs that somebody's here representing? Shout it out. Oh yeah, beautiful, of course. Anyone else? Yeah. Oh wow, okay, so that's pretty significant too. Good. And how many are curious about medicine as a career path for themselves? Okay, all right, good to know. And who here has a grandmother, a mother, a sister in medicine? Okay, And who here has a grandfather, a father or a brother in medicine? Okay, for some of, oh wow, so a lot of the people have both. Okay, so thank you for answering those questions. We'll go on with the main scope of the talk, which is women in medicine. So, I originally wanted to talk about the history of women in medicine in Canada. After a brief Google Scholar search, which is always what I use first, I realized that this subject was probably going to be a little more challenging to talk about than I first expected. My online searches yielded nothing in particular, not enough material that I could grab onto to make a timeline up until today. And it's not that I don't think the information is out there or that these women don't exist. I just don't think it's that easily accessible at this time. And I had to laugh a little because that initial search kind of frames how I feel about women's status in medicine today. Very real, very present, but with certain aspects hidden away from the public eye. Realities that I hope will become visible during my lifetime, if not yours. A little bit of history. So this text was gained from the Canadian Heritage website, which was very, very informative. And I'll start off by reading it. So the names of women are conspicuously absent from the lists of famous Canadian medical pioneers. During the 19th century, while male physicians and surgeons were exploring new treatments and innovative medical procedures, Canadian women were struggling for the mere right to even practice medicine. For them, acceptance into a medical school was a major achievement. The two women most responsible for breaking down the barriers and advancing medical training for women in Canada were Emily Stowe and Jenny Kidd Trout. Maybe try to memorize those names for some trivia game or something. Two names that also I found on my Google searches as being the first women who practiced medicine in Canada. In 1875, so a measly 141 years ago, Jenny became the first woman licensed to practice medicine in Canada. She grew up on a small farm in Ontario and was particularly good in school. And as a side note, if you do want to get into medicine, it's true that you must excel in your studies, because when you're in medical schools, the amount of information you have to remember is absolutely insane. I remember on the first day of class, I was literally given a telephone book of notes for the year. And I was like, oh, okay, that's pretty smart. You know, they just gave me the whole thing. Now it's out of the way and I can do whatever I need to do for the year. Until I was quickly corrected by my new friend. And she told me that telephone book wasn't for the next 12 months. It was for the next 4 weeks. Anyway, I digress. Now back to Jenny. Upon graduation, she took up one of the few career paths that was open to women and began teaching at public school. and then she taught until she got married. After an illness, she too was very motivated and inspired to take up a career in medicine. Her plans were encouraged by her husband, very important to have a very supportive spouse, as well as her longtime friend and mentor, Miss Emily Stowe, another big name, who had actually been practicing medicine in Toronto since 1867, although she was not licensed by the Ontario College of Physicians and Surgeons, which is actually the board I'm licensed by today, that and the CMQ, which is the Collège des Médecins du Québec. Thankfully for me, things have changed. Entering a man's world. During most of the last century, professional medical practice was exclusively a male domain. Hospitals were designed for the poor, since wealthy people could just have doctors come over and treat them. In most hospitals, nursing care was provided by sisters or nuns who were female, and in cases where lay women, or normal people, acted as nurses, they were treated as little more than servants. So basically, if you saw a woman in healthcare, wasn't really at the same status as a doctor. They had no professional respect. Florence Nightingale's campaign to create a nursing profession only began to have an impact in Canada in the late 19th century. I think it's important to mention Florence Nightingale's name today too. In this climate, it was not surprising that the male medical establishment was so hostile to the idea of educated and paid female doctors. When the Toronto School of Medicine reluctantly allowed Jenny and Emily to attend lectures, it was on the condition that they make no fuss, whatever happened. Those are in quotes. But plenty happened. Trout and Stowe were the only women in a lecture hall filled with men, led by the lecturers themselves. The male students jeered at the women. Obscene sketches had to be whitewashed from the walls 4 times. I'm not sure if you've all seen the Canada 1-minute heritage video that used to play on TV a few years back. Okay, many, many years back. But here is one of my favorites. I'm not sure it's gonna work today, but I can give it a try. Let's see.
Send them home! Get rid of them! Gentlemen, please. And so, this organ, which I regret I cannot play, because of the presence of these members of the weaker sex, who, although they are married, could not possibly endure. Get them out.
Mrs. Jenny. Patience.
Get them out!
Dr. McFarland!
Mrs. Trout.
There's no place for women in a medical school.
Get them out!
If you do not bring this classroom under control, I am going to repeat every word of this disgusting lecture to your charming wife.
My friend Jenny Trout was not the only woman to face this kind of thing in medical school, but she would become the first woman licensed to practice medicine in Canada.
All right. How many people saw that before? Oh, okay. All right. Good, so I'm glad I played it. Okay, so finally, Trout went to the United States for her medical education. She returned to Canada in 1875 with a medical degree from the Women's Medical College of Pennsylvania. Licensed to practice. Back in Ontario, Jenny passed an exam before the CPSO, that very same board, and she was complimented by them, except it was given to her husband for having such a talented wife. She went on to practice medicine at Toronto's Therapeutic and Electrical Institute, and her next objective was to establish a college for the medical education of women. After a long campaign, Trout had another fight to see that women could sit on the board of governors. Finally, the Women's Medical College at Kingston opened, supported by Jenny Trout financially, and the heroic struggles of her, who was essentially a quiet woman raised on a farm, whose life's aim transcended personal ambition, opened the door for many Canadian women doctors who came after her. So essentially me and a lot of my friends. So that's the story of the first female doctors in Canada. A somewhat rocky start, but what a finish. Let us never forget that because of people like them, the idea that young men and young women, just like you guys, should be segregated in Canada while learning medicine is actually an idea that I think we can all agree is ridiculous. They dared to challenge the routine. They made it the norm. And because of that, we have all benefited. Women in medicine, the statistics. So that was women in medicine yesterday. What is it like today? Let's start looking at the stats. So we have here that out of all doctors in Canada, 52%, let's just say out of all doctors in Canada, I'll say that 60% are currently male and 40% are female. So out of everybody practicing. And essentially it's a little like, you just think about it, 50% are general practitioners and about 50% are specialists. And this was based on Canadian Physicians Resources as of 2016. So, and the number of doctors in Canada is about 80,000. And there are about 2.5 physicians per 1,000 people. So I would just remember it like for every, 500 people, there's a doctor out there. What else did I want to say? In terms of the medical students right now, as of 2014-2015, 56% are actually female and 44% are male. So we're starting to see a switch in the majority of who makes up the class. I wanted to take a look at this graph as well. The number of active physicians by age. So this breaks it down in terms of how old these physicians are. So in the above 65 categories, so in like my parents' age group, you'll see, I'm just going to take a look at Quebec, you'll see that there were 2,453 male doctors and only 543 female doctors. So really there was a very big gender skew at that time. Of course, and then as you go up the graph, you'll see that things are kind of equalizing, and then you see present day, which is age under 35, it's sort of the reverse, where you have, 1,500 girls and about 700 guys in the class, which I thought was really interesting. The next graph looks at the average hours worked per week by physicians. So this is something that comes up a lot in discussion these days, I find, like when we're talking about long-term perspectives, what it means, a lot of people will draw out on this types of data. And I know you guys might have questions about this, and I would love to answer it at the end. So if you have some questions, just jot them down and we can talk about it later. But what I wanted to point out here, we're just going to look at the all physicians group, is that on average, people do work between 46 and 50 hours a week, which if you think about I guess the national average would be about 35 hours a week, which is I think 7 or 8 hours a day. I mean, it's significantly higher. So for those of you who've lived with a doctor or who've had a doctor in their house, who've experienced, their residency and their work, you know that it's a lot of work. And the average person works between 46 and 50, which means that, most people work more. I don't think people work under that. And this doesn't take into consideration the on-call hours, because that just skews everything. But I just wanted to give a realistic perspective of what that is. And this also points out that they have broken it down by the sexes. Males tend to work 4 hours more a week, okay? Now, this is a graph that I also thought was important because I wanted to see, have the trends been consistent over time. So this look, the window is pretty good. I'm going to just go straight to the end in 2014. Again, males work 50, women work 46, but that number isn't always stable. And what I saw from this graph is that sometimes it seems like the males, did vary as well between 48 hours and 56 hours. Now they're down to 50. The women were also between 39 and 47, sometimes 49 even. So really these numbers, they're not set in stone. It looks like things really do fluctuate as time goes on. And I think it's important to keep that into consideration for what I'm about to say eventually. So now we're going to talk about residency decisions based on gender. So the United States and the Association of the American Medical College, the AAMC, in 2015 published a report, and it identified the top specialties amongst their 86,000 residents. They did take Canadian data into consideration as well. So there were 4 top picks for women and 4 top picks for men. Can you guys guess what the 4 top picks for women were? Down there, yeah? OB. Very good. That's the first one on my list. So about 85% of OB is made up by females. Anything else? Just pick it. Yeah? Pharmacology? I think the closest thing to a residency in pharmacology is microbiology. And I think what they did here is that they didn't take into consideration the residencies that had a limited placement. Because I think in Quebec this year it was like 2 places. So I don't think they would have taken that. And pharmacology itself wouldn't be a residency spot. Did you mean like something else? Like psychiatry maybe? Probably not what you meant, but that's one of them, okay. And what am I? I fit the stereotype. Family doctor, yes, family medicine, and then think little kids. Pediatrics, yes, 75%. Very good. And what about for males? What do you think they prefer to specialize in? Surgery. Yes, very good. Surgery. What else? It seems like high adrenaline stuff a little bit. Emergency. Wait, did you guys say emergency? I just say yes. And then anesthesiology, putting people to sleep. And radiology, so looking at X-rays, CTs, and all those things. Okay, so this data found women were underrepresented in things like neurosurgery, orthopedics, which is when they work with bones, urology, general surgery, and radiology. And the studies found female medical students were more likely to enter programs with higher proportions of female residents already. So it seems that female medical students are encouraged by female residents. While these numbers are based on residents who graduated from programs in both the United States and in Canada, international medical school graduates also reflected this trend, which is actually kind of interesting. And they had the same gender-specific breakdown of specialties. So whether abroad or in America, specialties like obs-gyn, peds, and radiology show a huge gender divide. But why? That is the question. So I looked at some of the research. What does it say? In a study from 1996, 250 surveys were given to medical students at the University of Toronto with the aim of trying to see what factors affect specialty choice. The results were that males were more likely to choose a surgical career, males were more likely to identify technical challenge, earning potential, and prestige, whereas females were more likely to identify residency conditions, part-time work, and parental leave availability as the most important qualities in the specialty. Females were less likely to take surgical electives and more likely to identify a lack of role models. So they didn't really see anybody that they were inspired by who was also female. Students all agreed that surgeons have rewarding careers and earn more. However, they did not agree that surgeons enjoy spending time with patients or have rewarding family lives. The conclusion was that fewer females than males were found to consider or choose a surgical career, possibly due to the differences in qualities of importance of the specialties, the availability of role models, and the lack of exposure through electives. So in medical school, there's some spots, there's some months where you get to choose what you want to do. And so a lot of people will choose to do, radiology in a month. A lot of people will choose to do something else. So they're saying that a lot of female students don't even do surgery in their electives. So that was the first study. In the second study I looked at, I looked specifically into why more females are in family medicine. And this study looked into the factors that were related to the work and well-being. It took into consideration that the role of female physicians, which often involves combining medicine, marriage, and motherhood, may cause some stress for some women. The purpose of their research was to identify rates of depression, stress, and to look at self-esteem among a sample of family doctors. And these people were located in London, Ontario, so not too far from us. In the results, 65% of females felt overloaded or overwhelmed at least once per week, but there were lower rates of depression. So I thought that was also really interesting. And the third study I wanted to bring up discusses productivity, which I have to say a lot of the current debate is centered on these days. In this article out of the University of Ottawa, the differences in work patterns were examined and overall doctor productivity. It concluded that female doctors work on average 6 hours per week less when compared to male doctors. They tend to work less on-call hours per week and see fewer patients while on call. So that means if I'm on call, it means that I would be seeing fewer patients as my 24-hour shift than somebody else. They were also more likely to take parental leave or a leave of absence, adding that gender has a significant influence on the practice of patterns of doctors in Canada. If the gender-specific work patterns described in the present study persist, they said, an overall decrease in doctor productivity is to be anticipated, they say. So they basically say there's not going to be, well, they kind of say in not so many words that there's going to be a lack of doctors due to the amount of fewer hours worked. I would like to point out that nowhere does it say that the extra hours per week actually resulted in better patient care or in patient satisfaction. Now, we're coming to the crux of this talk. Why should we care? So what do all of these things mean? Why am I up here today telling you about all these things? I think it's really easy to walk out of here and think that women in medicine is leading to less productivity, and that's a reason we should all worry. Our current health minister, Mr. Gaétan Barrette, would have you think this way, and it's such a harmful thought. He's often used women in medicine as a scapegoat for why he thinks that family doctors are not as productive as they should be here in Quebec. He blames this lack of productivity on why people in Montreal struggle to find primary care physicians. But he never talks about how limited the number of licenses are that are given to people who apply, who actually want to work here. How only 50% of applicants who apply to the City of Montreal actually get them, forcing the other 50% out of the province. I've heard a lot of people within my profession openly talk about how women shouldn't even be considered for surgical subspecialties for the fear of them getting pregnant during their 5-year residency. And once, I was even confused of trying to take advantage of the system by an older female specialist, since I casually asked if maternity leave was paid while in residency. Mind you, I was asking strictly out of boredom and curiosity, and more to make conversation at an informal medicine discussion dinner group. Not gonna lie, it got a bit awkward. But it also points out that men aren't the ones to blame. There is a problem within the culture of medicine, the patriarchy of it, that almost everyone, men and women, seem to be very comfortable in. And I hope that after this talk, we don't think that the supposed barriers that women face in medicine are valid excuses for why we should exclude them from any profession. If I fell into that trap, I wouldn't be doing feminism any justice. The point is to see beyond all this rhetoric and to realize what's going on in society for women and why we struggle. Why is it so easy to make us the scapegoat? Why it's so easy to speak to an audience in numbers and stats in order to make them think a certain thing against change, and not concentrate and actually create real equality, which I think, if achieved, will lead to solutions rather than to enforce barriers. Sometimes in medicine, we get bogged down with numbers and stats and lose concentration on the true issue, which is women still have an upward climb. Of course, there are reasons why the numbers per week worked are lower. But what are they exactly? And if it has anything to do with maternity leave and childcare, why don't these numbers recover when women enter their older ages? Why is it that women are still doing the majority of the housework and childcare? Will this change? Does the declining number of hours a week worked by men over time reflect that they're taking more responsibility at home as well? What can we do to make the numbers the same, if in fact they even reflect better patient care, which hasn't even been linked? Do women work a few hours less on average because they deliver more in-depth patient care? How do we go about understanding these stats in a positive, productive way? These are the questions we need to be asking. This is the way we need to look at the data. Blame and systemic suppression will take us backwards. Women have come such a long way from 150 years ago, when there were 0 female doctors in Canada, to today, where we comprise over 50% of the class. I am so proud of that reality for our country and what it means in the greater sense of achieving equality. Of course, there's still a lot of education to be done, and it'll take people just like you to understand what the issues are and advocate for securing a just and equal future for us all. Thank you so much for giving me a platform to discuss this today. Your presence makes me so happy that there are people so young and so motivated that want to come and listen. Thank you also to Stephanie Felkai, who has graciously organized me to be here. I know she had a lot of other people helping her. And Michael Ancioni and Andula Dunavis for the initial interest in getting me to talk. I wanted to add, I wanted to add that sometimes life really does come full circle. And this is one of those moments for me, because it was, a while ago, I was sitting in the end building, probably with Michael, just like you, looking to find my way. So thank you. And now we can maybe have some questions? Yeah? Okay.
Wait till the questions.
And I'm going to have a cough drop.
Maybe if
Does anybody have any questions for our speaker today?
there was one here. Can you speak loudly, or you can come up for the mic? Questions?
Yeah.
Like when you said that you did work in India and Bangladesh,
Yeah.
What organizations were you working through?
Yeah, it's a great question. So after my master's, I decided to volunteer in India through an organization called Sheila Bal Bhavan. What that means, Sheila is the name of a woman, and Bal Bhavan is basically saying a home for young children. Okay, and at that home they wanted it to be mixed, little boys and little girls, but they found that it was easier just to have one sex, so they chose little girls, because in that part of India they are more disadvantaged. So I worked there, and my aim was to provide HIV counseling and STI prevention for these young girls. It was interesting because to discuss these topics with such young girls and in a different society, it came with a lot of barriers. And towards the end of my few months stay, I changed it to sort of talk about how to keep yourself safe, physically, how to keep yourself safe from harm, and what, if they had any questions about sexually transmitted illnesses. So that's how I sort of broached that one. In Bangladesh, it was an interesting program through our government. It was the International Youth Internship Program, which I'm actually not even sure, if it still exists. But at the time, they were taking applications from young people without much experience in their field. And so I got placed in Bangladesh in a non-governmental organization called Young Power and Social Action in Chittagong. And there I worked with street-based sex workers, again to talk about HIV and AIDS. But, you know, I'm like this Canadian girl going to Bangladesh, basically talking to, you know, sex workers about STIs. They knew about it already. So essentially, you know, we transformed it to it being a little bit more about reporting what the actual condition was and writing a newsletter for the community and taking a look at the census. So it was super interesting. But you have to get, if you want to do development work, I find it starts off one place and it ends up in another place, and you have to be quite inventive to like find out how you really fit in. And if the skills you have to offer aren't really relevant, you kind of have to change that around, you know? So super interesting. I would have, and like I said, like I would have probably stayed in that line of work, but that medicine bug just kept on creeping in, so I had to change.
How do you think your career is going to affect your family life?
It's a good question. So, I mean, how will my career affect my family life? I know that my residency and medical school already affected my friends, my family. I think they saw certain changes in me because my life had to become extremely regimented, and I think that they had to kind of understand that I was going through a period that was very, very, very demanding. So like the way medical school works is that it basically plans your life for you, and it's very fun, and I'm so happy, but it leaves very little time in between to be like a free spirit, okay? Like somehow I think I still managed, but it was tough. And I think at times during third year of medical school at McGill, when you really start doing the hospital rotations, because the workload is so high, I felt like we all felt like our nerves were a little bit fried. And we were all working, I would say, anywhere between 45 to 75 hours a week. So it doesn't leave too much time for sleep. You know, you need to have a really supportive boyfriend or a girlfriend, or, you know, everybody in your life sort of needs to know what's going on. People who've grown up with doctors in their house, I think that they've probably seen it. And although it's not necessary, I didn't grow up with a doctor in my house, but I kind of get it now, you know? Like, I think I kind of went in thinking that, you know, the medical part of, you know, the academic part of it isn't going to really be hard, you know, and I just want to make friends, and it's going to be fun, and yeah, it's going to be challenging, but how hard could it be? And it was pretty hard. And sometimes keeping your calm demeanor was a little bit tough, but I think that's how it affected me before. How it's going to affect me now is interesting. I think that whoever I end up with is going to have to be extremely supportive, you know? Like, I think about having children, and I think about, you know, doing all my projects. Whoever that person is going to really have to give 100% just like me in order to move forward. And I would be pretty reluctant to enter some union without feeling that was going to be a given. You know, so I think when your time constraints are so high, you know, and like you travel over work so often, and like, you know, and people feel that you should be doing the childcare because you're a woman, it's even more on your mind, because for me, I'm like, oh, well, that's not, if that's the stereotype, and if that's what's going to be expected from me, they're going to be disappointed, right? So I think that's how it's going to affect me. Like, I'm going to be very careful, you know, and as we all should, I guess, with our life partner. But supportive ones and childcare and, you know, home care is even more important, I think, at this point, because I know I'm not going to have time or to do as much. Yeah, a good question.
Any other questions?
Mm-hmm. Yeah, go ahead.
You give us, you did a residency?
Mm-hmm, yeah.
Can you give us a few words of how it went, and if you felt a certain injustice towards women in the residency, or just very subtle things that you noticed the difference?
Like for women and men in residency, what the differences were? So I did my residency in family medicine at McGill through St. Mary's Hospital. I have to say it was a very positive experience. I did ask my friends in residency recently, I'm like, did we experience anything? You know, one friend told me that she only one time, she was like seeing somebody, a man in the ER in his 50s, in the emergency room, and he wouldn't want to tell her the story of what happened because he thought she was not capable as a female. So she reported that to her supervisor. I was aghast. I mean, I've never heard of this story before. She reported that to her supervisor, and her supervisor spoke to the man and stood up for her student. So there was that. Personally, with me, luckily, I don't think that there was anything visible, you know, that happened to me. Nobody ever said anything. A lot of times, if you're hospital-based, so for my hospital-based rotations, they just assumed I was the nurse, which, you know, is okay. I mean, I would be proud if I was, but it's the assumption, you know, like if I'm with a male student and, you know, and female were exactly the same thing, they would always think he was the staff, and they would always think I was the nurse. So that was something I noticed. But apart from that, luckily, I didn't feel like there was obvious discrimination or anything like that. It was tough because the hours were so long, but not because I felt I was female or anything and that people were trying to put me down. No.
I've heard about maybe like different races, different cultures. If they felt anything.
So, okay, so if people from different races or different cultures felt anything different towards me, no, luckily, what's that?
Towards themselves, other people who did residency.
Oh, like if they were experiencing some type of discrimination? That's a good question. I felt like if somebody was from a different culture, they would prefer to see a resident of the same culture, you know? That was definitely true. I felt like, I did feel like in obstetrics and gynecology, when women of a certain culture were giving birth, they wanted a female resident. And I felt that was a little bit tough because the males deserve just as much experience as the females, you know? So that was true. Whether or not there was any frank discrimination against, you know, people of an ethnic minority, I personally never saw nor I came across. It would be interesting to see because we do actually have a lot of spots for people from Saudi Arabia who do residencies here in the specialties. So that would be an interesting question to ask one of them, you know, perhaps that they've experienced something, but not that I've ever seen. Luckily, I feel like people in Quebec are quite happy to see doctors, and unfortunately the nurses get all the attitude when they're waiting for like 10 hours, but then when they finally see the doctors, they're pretty good, you know, they're happy to get the care. I haven't experienced anything too bad. No, never actually, which is pretty remarkable. I mean, Montreal is a pretty multicultural society. I think people here who've been here for a while kind of know the drill. I think generally people treat each other with a lot of respect. And what I was talking about today is more like, I feel like it's more hidden, you know? Like it's not really, the sexism in medicine it's not really obvious. It's not like how we saw in the YouTube video where it was so obvious and people are berating them for being girls. It's not like that. It's more like this systemic, like, I was talking to my friend in oncology today and she said, because right now it's CARMS, so when you're in residency, sometimes if you want to go into another specialty, you have to do this match. So she was talking to one of her friends who's trying to get, you know, into this oncology residency, and she told me that she was asked by her interviewer if she plans to have children in the next 5 years, which, you know, you're not supposed to ask. CARM says you're not supposed to ask this, you're not supposed to answer these questions, but they are asked all the time. And, you know, they can be a little bit like, not as obvious about it. They'll just be like, oh, how old are you? Are you married? You know, like, when'd you get married? And so I think that, the assumption is, of course, you know, oh, well, we don't really want to take anybody who's going to be taking off, right? Like, so I think in that way, I feel like it plays out. But in the obvious way, luckily, there's very few stories that I've heard of. No. Thankfully. It's a pretty good environment in that sense. No. No worries. Yeah.
I don't know if I can ask questions.
Yeah, of course.
I'm curious about a couple of things. For example, the government, basically the med schools decide how many medical students are going to take based on the government numbers and who they're going to allow?
Yeah. Yeah, so Quebec has, you know, a given number of seats, and they decide this based on what the projected amount of need they think the society is going to have. And over the past, I think it's like, I don't know, 10 or 20 years, the numbers of enrollment, they've had to make them go up by 85%. So McGill's class used to be like around 100, maybe 15, 20 years ago, and now my class, I think it was slightly over 200. So it's like, or it was about 200 with the dentistry students, it was maybe 200. So they really had to scale up how many people do medicine in the country and in the provinces. It's of course province regulated. Yeah, is that answering your question?
Yeah, and I'm wondering if, like you say,
The
Vanier,
yeah.
he seems to be wanting to cut that back from
Yeah.
that number, or he wants to like just keep it status quo.
It's difficult for me to understand what Barrett's long-term projection is, because I feel like he's not that forthcoming with it. He feels that family doctors, this is what I understand, feels like family doctors in Montreal don't have enough patients registered under them. And he feels like it's because a lot of people work part-time, and he says that a lot of women work part-time, and this is the reason why everything is crumbling down. I completely disagree. Nowhere in the country are there a fixed number of license that you give to a family doctor within a city, and just basically regulate it like that. Like, I mean, I think a more suitable approach to solving this type of problem is not to force the family doctor who already has 1,000 patients registered to take on more, but more to make it open, and as long as you have your license by the CMQ, you're able to practice medicine wherever you want in the province, just like it is in Ontario, just like it is in every other province. So, you know, on one hand, they really limit the number of licenses that family doctors can have in Montreal, and on the other hand, they feel like the people who are working aren't able to meet the needs of society. You know, so it's a little bit puzzling to me, and especially because it's a fee for service trade, which means that let's even say that people work part-time. Basically, two people working part-time, because it's fee-for-service, meaning like I only charge the government for who I see, I'm going to charge them half of what I would have charged if I was full-time, right? So if there's two people doing one job and you're just paying each person half, I don't understand why it's such a big deal. And yet, the way he paints it is really not, I don't think, true, and I think it really makes women look like we're not up for this job, and I don't even know what he's suggesting. Like, yeah, go on.
Well, I'm curious because you seem to paint a picture of like, maybe there's that work ethic thing, like, for example, like my brother in a different field feels he would never be able to even take paternity leave because he would be out of the game,
Yeah.
lose gains and this and that. And that whole cultural, like, and it's funny it's applied to men, especially that you just told us that it's paid per service.
Yeah, fee for service, as staff.
So I was curious about that culture and why, in your mind, why it's like it's pushed forward, and at the same time, the idea also that you said that I found it very interesting, that it's not men who are responsible for pushing, but women also, and there's some sort of maybe cultural ideal that's that they're trying to slot in, but where maybe you're indicating that less work on the job gives you better care.
It's been suggested.
Yeah.
It's definitely been suggested that, you know, perhaps that's the reason why things are the way they are. In terms of, and I think it's really interesting that the two personal cases I know of where, you know, a senior doctor kind of gave slack for asking about maternity leave, both of them were senior female doctors, okay? And in the situation that I was in, you know, the one I was spoken to, you know, she's very nice, but basically she was saying like, oh, well, I had my kids during residency and, you know, I was fine and I didn't have to take time off. So I think it's very much based on, I went through this system and now you guys stop complaining, you must do it the same way we did, you know? And I think that it's more of like this ownership, like because they're women, they feel like women also need to prove themselves, that they're up to par with working, you know, regardless of the fact that they're pregnant, regardless of the fact that they may have to take that year off from maternity, you know, without really taking a look at some realistic factors like, you know, that a lot of people who have children, you know, in medicine do tend to have them later on because they've waited, you know, for their studies to be over. And, you know, maybe their nuclear family isn't able to be as involved with the childcare as it used to be, you know, 50 years ago. And maybe their own husband isn't something very, very demanding as well. So I think that, again, it's the culture. Because I don't really think it's based in stats. I don't think it's based in patient care. I really think it's based on this is how it was, and this is how it should move forward, without really taking a look at the social literature or even, you know, much of the medical literature into what creates a positive health environment for people. And, you know, with men taking paternity, I don't know I think there is paid paternity leave during residency. I know in surgical specialties, it is so hard to take it. And, you know, and I think for that reason, a lot of females get a little bit turned off. Like, if it's so hard to take off a week or two, what's it going to be like if I need to take off a few months, right? So I think there's a lot of, like, systemic deterrents. You know, and maybe solution, you know, and I don't think these should be barriers. I think women should be surgeons. But I think we need to look at, okay, what's going to make it easier? What's going to make it feasible for these women to actually go into surgery and, you know, and have a great career in surgery? We don't want the fact that they have 1 or 2 kids during this time to affect the rest of their lives. I mean, to me, that's a backwards argument, but it's really easy to fall into that trap. And I feel like a lot of the people I worked with and a lot of the doctors I spoke to, it's becoming repeated, you know, more and more. Because now we're seeing, you know, under the 35 group, that there's way more women than there are men. And I think people are like, oh, what does this mean? You know, like it's first time and it's a little bit scary. And so they're pulling out those types of data. And again, we're not talking about like 50 hours less. We're talking about a few. And even then, if you take a look at time, that's always been fluctuant, you know? So it's an interesting culture, let's put it that way. Anyone else?
Yeah, about the stats for the women who work about 4 hours less.
Yeah.
Does that count women who are away on maternity leave, say 0 hours work?
No, they didn't take those people into consideration. No. And they didn't take the on-call hours either. Yeah. Yeah, no, so it seems to be real. I'm not disputing that at all. Yep. I didn't hear the question. Do you want to come up a little bit closer? Yeah. 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 Do I feel like Canada is more advanced in the giving of medical care? Inequality? For what? Oh, it's a good question. I didn't take a look at literature from other countries. I think it's quite comparable to what's happening in the States and what's happening in England. But apart from those two countries, I'm not sure what's happening internationally. I think Canada looks like it's becoming a leader. I mean, if we look at the sheer number of the people under 35, you know, like there's so many women, which is wonderful. So yeah, in that sense, based on that data, I would say yes. I'm not sure what's happening in other countries. I feel like Australia, England, and US probably have similar trends. I hope that they do not deter their female students from going into surgery or radiology or anything like that, but I don't know. Yes?
Could you imagine a class today, like that you went through, being only female or only male? Like imagine what they were trying to segregate. Could you imagine that?
Well, I mean, I think it would be very sad if we didn't have equal representation of the sexes. You know, I think it is very important. I think it's very important to have, you know, a lot of men and a lot of women in something like healthcare, and especially in being a physician, because it's true that, like, you don't know, in family medicine, you really need to relate to your patient, and you really need to find a bond, and it ends up being a lifelong bond if you stay in the same place. And it's a very sacred bond, I find. And I think that if it only became one sex or another, it just wouldn't really be fair, because our population isn't one sex or another, you know? Like, so I think it should really reflect what the population is. And I think it would be, yeah, I just don't think it would be right to skew it too much in the favor of one or another, you know? If it was like it was all men back in the past, I don't think that was good at all. Yeah. Well, thank you so much for listening. Thank you.
Guys, just a minute. We have set up 10 laptops outside. You just need to enter your name and your teacher's name on a survey monkey form. It takes 10 seconds. Okay? Laptops outside. Enter your name and your teacher's name.
I'll leave this here.
Cameras guys inside. Just like crouch underneath this camera.
Walk in there, right?
If I wanted to go home, I wouldn't make it in time for the next class.
Thank you so much.